Welcome everyone. In this video, we present the surgical management of a 67-year-old gentleman who presented with a subluxated posterior chamber intraocular lens following cataract surgery performed elsewhere. The existing capsular support was inadequate for repositioning, making IOL explantation followed by glued scleral-fixated IOL implantation the preferred approach. We begin with a conjunctival peritomy and create two partial thickness scleral flaps exactly 180 degrees apart. This is a step that deserves patience. Symmetrical flap construction lays the foundation for good IOL centration at the end of surgery. Uneven flap placement or excessive scleral thinning can make subsequent maneuvers unnecessarily difficult. Trocar anterior chamber maintainer infusion is fixed and sclerotomies are then fashioned beneath the scleral flaps. Maintaining equal distance from the limbus on both sides is essential to achieve stable and well-centered fixation of the secondary IOL. If there are any vitreous strands in anterior chamber, meticulous anterior vitrectomy is performed wherever vitreous prolapse is present. Any residual vitreous strands can lead to traction during lens manipulation, increasing the risk of retinal complications and post-operative inflammation. The previously implanted capsular tension ring is carefully disengaged and removed along with the unstable IOL. Although a CTR was present, the remaining capsular support was insufficient to provide durable fixation. Rather than attempting a temporary rescue, complete explantation allows definitive visual rehabilitation with a stable scleral-fixated lens. A thorough posterior vitrectomy is performed. The IOL is cut and manipulated out through the clear corneal incision. A three-piece intraocular lens is now introduced into the anterior chamber. The leading haptic is externalized through the prepared sclerotomy, followed by handshake-assisted transfer and externalisation of the trailing haptic. This remains the most technically demanding part of glued IOL surgery. Maintaining a stable anterior chamber and ensuring continuous visualization of the haptics greatly reduces the chances of losing the trailing haptic into the vitreous cavity or inadvertently damaging the haptic. Once both haptics are externalized, intra-scleral tunnels are fashioned and the haptics are securely tucked. A well-constructed scleral tunnel provides long-term mechanical stability and minimizes the risk of post-operative haptic slippage or IOL decentration. Before proceeding further, it is always worthwhile to confirm that the lens is perfectly centered and that both haptics are symmetrically tucked. Fibrin glue is then applied to secure the scleral flaps and conjunctiva. A dry scleral bed allows optimal adhesion and results in a smooth, self-sealing closure without the need for sutures. The surgery concludes with a stable, well-centered, glued intraocular lens, a well-formed anterior chamber and secure wound closure. As with most complex anterior segment procedures, success is determined not by one difficult maneuver, but by consistently executing every small step with precision and respect for the ocular tissues. Thank you for watching.